Okay, great. So thank you all for joining us today for our November learning session. Like I said, we have quite a few teams that are going to present today. So I'm going to go ahead and just get through our beginning slides, and then I will turn it over to you all so that we can hear about the wonderful work that you all are doing. So to begin with, our general acknowledgement that we are supported in part by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services under the following grant number. And the information or content and conclusions are those of us and should not be construed as the official position or policy, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. This activity is approved for continuing nursing education by the Emergency Nurses Association for 1.5 credit hours. In accordance with that, we need to note that none of the speakers or planners for this event, which includes Dr. Kate Remick, Diana Finja, myself, and Crystal Bartley, have any conflicts of interest. Additionally, no commercial support has been received for this activity. Should you detect any bias in this presentation, please note such on the evaluation or reach out to Diana Finja, our nurse planner for continuing education. So to obtain nursing CEs, you must sign into the webinar with your name, email address, and name of your facility. At the completion of the presentation, a link will be provided, and I'll put it in the chat box, which will take you to a short evaluation form, which you need to complete. Now, this needs to be completed within 2 weeks of this session in order to get credit. But once you complete this within 48 hours of receiving your evaluation, you will receive a CE certificate electronically. There's also a QR code here in the bottom right that will take you to the survey as well. So here's our agenda for the day. We're going to do, the majority of the time will be spent on team presentations. We'll start with the Longhorn kids, followed by Ada's Enough, then ETCH, Fight or Flight Response Team, LifesavERs, Lone Star Kids, New England EMSC, and finally we will end with Oregon. If we have time, we'll review some of our aggregate performance, and then I will go over a few housekeeping items at the end. So with that, we'll go ahead and jump into the Longhorn kids. If Dr. Ayer, you're on the phone, you can go ahead and take over. And just tell me when to advance the slides. I'll just keep control for everyone so we can save some time. So take it away.
Thank you all for being with us. I'm Sujit Iyer, one of the PTR docs here in Austin, and Danita Lyons, who's not on the, actually maybe on the call, is our education director, both for the Children's Hospital and for our network. So we just move on to the next slide. Just a brief description. This is who we are. We had 2 great nurse trainers who've been out to our sites and continue to reach out to them. We'll talk a little bit about steps we've made forward and kind of obstacles we've had in terms of pushing farther on the vital signs. You can go on the next slide. So just a description of where we are. So we're in Austin, Texas. We have 11 affiliate sites. We are a pediatric hospital that is within an adult hospital network, Seton Family of Hospitals, which is part of the larger Ascension network. Our center itself sees 78,000 visits. But we highlight the fact that all of our community EDs together see 70,000 visits. This was one of the cells that we had on why this QI project was important to our CNOs, is that each of these hospitals in and of themselves may see a low number, but together they represent almost an entire children's hospital. Our lowest volume hospital that we work with sees as little as 300 a year, and our highest volume sees 9,000 a year. It is actually a level 2 trauma facility. So a big variety of staffing. This is a description of all of our hospitals and our pediatric readiness scores prior to the start of this quality improvement project. If you look up in the title, you can see that 3 years ago, Kate Remick, actually who also lives here, led a team that improved the mean pediatric score at every single one of our sites. And so across the network, we were averaging about 65. After some targeted improvement a couple years ago, we improved pediatric readiness scores at all of our sites. We have a variety of sizes in terms of our number of pediatric beds, as large as 41 in our adult trauma facility, and as small as 6 in our rural sites. Our 2 bundles that we focused on were weighing kids in kilograms and recognition of abnormal vital signs, and for us, really obtaining a full set of vital signs was a big focus. If you move forward. We were very lucky that Kate Remick and a prior team had already introduced the concept of pediatric readiness, and so we were not reinventing the wheel. We were trying to build on prior success and recognize that most of the prior pediatric champions were now in different roles. And so we had to re-explain the project to ER managers and remind people why this was important. Our goal was that we would be able to establish a process where greater than 90% of kids that we looked at would have both weight and kilos, and that they would have a full set of vital signs and be identified as being abnormal. And so this is kind of, next slide. So our barriers are probably not different than many of yours. We had a revamping of our entire educational team for the network, where education was centralized to a few limited number of people who had to cover multiple hospitals. Most of our pediatric champions were in new positions, so we had to try to find new ones. Some hospitals were growing and reaching out for other designations, which were competing with our interest of focusing on pediatrics. Our pediatric specialists don't really go to these other hospitals, and so we don't have a continued pediatric presence. And the ability to get staff to actually pay, to have time for education is tough. And at least one of our systems was actually still paper up until just this past year. We did have leadership support from the C-suite. Our leadership also at Dell Children's, which is the children's hospital, even put forth a bucket of money for nurses that wanted to take time to teach at these hospitals. And we actually put together a quality improvement package that fit the nursing promotion schedule to try to recruit new champions who may be on that promotion schedule. So here are some interesting things that we had to do once we started moving forward on this project. So we actually did have on-site education where we went out to each of these sites and we talked to frontline staff, and we're doing some troubleshooting on both the weight and kilos and vital signs using the bundles and the intervention packages that were provided through this project. We created laminate cards for people to have and to carry with them. We ensured that 100% of our scales were locked in kilograms. And we actually, while we were there, did a rudimentary supply checklist. So one of the peripheral benefits from this project is that by going out to these sites, we realized that even if sites thought that they had all their pediatric supplies, most of them didn't, or they were expired. And so we got the executives to agree to a supply expiration policy where any community hospital that had a supply that was about to expire, they could exchange it for a new one with our pediatric hospital. Since we were part of the same network, that was a little added benefit and act of goodwill. What we quickly realized was that weight in kilos was kind of easy, but that obtaining a full set of vital signs continues to be the challenging one. When we met with most every site, there was at least a large percentage of nurses that thought that you did not need to get blood pressure or a full set of vital signs on kids. And at the minimum, every single one of them acknowledged that they found it challenging, if not impossible, to get a blood pressure on a young toddler or a crying baby. We brought this up to nursing council and actually got this flyer, which you see, which we actually got a formal statement as part of the policy to confirm that kids actually needed a full set of vital signs. We took some of the work of this project, presented the evidence, and got the nursing executives to agree that blood pressure is required on all pediatric patients. So that kind of gave us some enforcement of what we were trying to do. You can go on to the next slide. So over a 2-year span, over the last 2 years, this is kind of where we stand. And so this is the total volumes that represent volumes over the last 2 years. This is kind of the cumulative total over 2 years. This is not over time, which we'll see in a second. A disclaimer for this data. So we do not have a lot of manpower to enter in charts manually. So we've relied on analytics to try to build us some dashboards for this project. Kids who were all paper charted because they were either codes, do not show up on this. And patients that were discharged, auto-discharged, they were not also included in this. So what you see in the third column is that the majority of kids were actually weighed in kilos at our larger volume pediatric sites. The two outliers were Del Seton Medical Center, which is our adult trauma hospital. They were converting over their EMR when this happened, so the assumption was they're still weighing themselves in kilos. However, when you look at vital signs, which is our fourth and fifth column, it was very rare for any site to be over 75% for a kid to get a full set of vital signs. And what we try to make as a network-wide metric is for having hospitals be able to hit both metrics together, meaning they weighed their kids in kilos and they got a full set of vital signs, which is your last column, which is the metric that gets sent out to our executives. Go on to the next slide. So this is that metric graphed over time. So this is the percentage of all kids in our network that got weighed in kilos and had a full set of vital signs. What is not shown here is how the lower performing hospitals kind of weigh down the higher performing hospitals. And so thus the ceiling is right at about 70%. And so we now finally are able to kind of show folks that basically if you're a patient that walks hesitantly and one of our community EDs, at least 1 out of 4 kids are not going to get a full set of vital signs, but most will get weighed in kilos, despite kind of the education that was done on site. You can go on to the next slide. So where are we now? So we're going to create slicers for the dashboard that I just showed you so that every site can actually kind of see their performance over time by site. We are going to emphasize the good things that they've done for weight in kilos. And we are now starting to talk to sites about what are the gaps for getting a full set of vital signs. We recently had done an outreach project at 2 of our sites for intranasal. And one of the things that worked well was that we created a YouTube video on how to do this. We are now in the process of creating a YouTube video on all the tips and tricks on how we measure kids for proper blood pressure cuffs, how we actually get kids to calm down. And we're then going to, after we do that rollout of information and we have our slicers, we're going to give each site their own report card on how they're doing on full sets of vitals and kilos, and start developing action plans with their executives. I think that's all I have for us.
That was great. Thank you. Any questions for Dr. Ayers? It sounds like you have a lot of buy-in from your leadership, which seems really key to helping this be successful. Anyone else have any questions?
Meredith, this is Kate. I just have a comment, which is just to say that Sujit's done and his team have done really incredible work with this network. And as you all can see of how much progress they've been able to make over the last really year and a half or so that he's been working on this project. And he's certainly integrating some of the aspects of the work that we're doing as part of PRQC. But as you can see, there's a lot of work that he's doing on the side. And I think the way that he's gone about engaging executive leadership is really a nice model to follow and a best practice. So if folks have questions about how to do that or more details about that they would like about that, then I would encourage them to reach out to you, Sujit, because you've done a phenomenal job of that.
Thanks, yeah.
Yeah, I'm Darlene in Nevada. And can you spell your name for me since I'm audio for this?
Oh, yeah. Last name is Iyer, I-Y-E-R.
And may I just thank you, this is because I say as I'm fairly new, This is really, really helpful to me.
Awesome.
Yeah, I would hope that if we can make this YouTube video, I think in the next couple of months, I would be happy to share it with everyone if it helps with education. I'm hoping that it is the kind of tool that shows each of these sites that they have the tools to educate themselves on it. And I'll just say that the executive, it has been hard to implement some of our quality improvement initiatives. Like we wanted to have kids have less CAT scans for appendicitis, or we've tried to focus on pain control, but this is like a real easy one when we show executives and staff, like you're not doing a full set of vital signs. I think it really then, once we create the educational tool, it really kind of creates the imperative that it just has to happen because there's no real reason why it shouldn't happen. And everyone acknowledges it as a safety risk. So but when we get that, hopefully YouTube video made this year, we'll share it with this group.
Thank you.
Great. Okay, if there's no more questions, we can move on to Dr. Arroyo with Maimonides Medical Center with the team 8 is enough, and they are working on the disaster bundle. So if you want to take it away. And just a quick reminder for everyone to please mute your phones if you're not speaking.
Hi, can you guys hear me?
Yeah, we can hear great.
Great, wonderful. So it's Maimonides Medical Center. Everybody has a hard time saying it. My name is Dr. Arroyo, Alex Arroyo. I'm the director of the pediatric ED here. You could go to the next slide. So we decided to do here at Maimonides the disaster bundle. After the pediatric readiness survey, we were 99% prepared for any pediatric emergencies. We are a tertiary care hospital. We see about 40,000 pediatric ED visits a year here. We have a children's hospital that's attached to the main hospital. It's really the hospital within the hospital, but the ED is a little separate from the main hospital, and we have a separate pediatric area, has about 20 beds or so, and we see our 40,000 in that 20 space. We're a level 2 trauma center for pediatric ED, which is a designation that we got about 2.5 years ago. Next slide. So we're part of the New York City Pediatric Disaster Plan amongst other hospitals. This is the draft version that still hasn't come out officially, but we'll talk a little bit about it. Next slide. And we're a Tier 1 designated hospital staffed with specialists and resources necessary to manage treatment and facilitate recovery required for pediatric patients. We have pediatric surgical service, emergency service, intensive care unit, inpatient unit. We have a level 5 nursery, I believe, and comprehensive pediatric subspecialty support, along with anesthesiology, neurosurgery, orthopedic surgery, who have experience in children. And we have a disaster plan, including a ped surg capability. And as a Tier 1 hospital, we received the red, orange, and yellow triage children. Next slide. This is the triage modification system. If you guys hadn't seen it before, obviously the children triage black don't really make it, but we can take care of the kids below that. Next slide. That's where we sit with the other Tier 1 hospitals in Brooklyn. Again, we're designated pediatric trauma center, the only one in Brooklyn right now. Next slide. This is the map of the hospitals in the Brooklyn, Bronx, Manhattan, and Queens area. We are right above that, in Brooklyn, that H. It should be a yellow H. It's actually a red H because this is the old list, but we should be a Tier 1 pediatric hospital with trauma capabilities. Next slide. This is our incident emergency management leadership tree here with the top-down incident commander to the director of security. This is just, showing the key players in place. Next slide. And here's a portion of our initiation process for any emergency incident. It goes down from the CO or the administrator on call for the initiation, from our data, depending on what happens for the event, to the alert, and then obviously depending on what the disaster is, what response we actually need to have, and then the departmental response that we get from the different departments. Next slide. So we instituted this rapid discharge protocol in the ED. So if we get a call for any disasters, this is what we're going to use to try to get the patients in the ED who don't need to be there out to a different place. It's basically just a non-EMR style rapid discharge plan that we have. Patient name, MR number, location, what their status is right then and there. If they're admitted, different story. We'll see if we could deal with those patients. But mostly it's going to be the patients that are going to be a definite discharge that we want to just get out of the ED as fast as possible to get to a different site. For admitted patients, it's the next box there. Which bed type do they need? Are they waiting any test results? Can they go upstairs ASAP? Are they waiting transport? For other patients, do they need test results prior to getting out of here? Does it require any treatments prior to discharge? Do they require any social services, interpretive services? Is the patient on a ventilator? And what's their discharge or transfer destination? We have the option when we have a disaster to send patients to the outpatient clinic for pediatrics if they're not critical patients that need emergency services. Next slide. This is our rapid discharge protocol for PICU in the PEDS floor upstairs, very similar to the one from the ED. You know, we'll decide what we could do with these children, what their respiratory status is, if there are any bronchodilators, IV drips, what their disposition status is going to be. Can they be discharged out of the hospital specifically? Could they be transferred from the PICU to the floor? Are they downgraded, again, from the PICU to the floor? Or do they need to stay at their current level of care? Or a different option that we have, can we move the patient if they're older to an adult unit? Can they go to the operating room or the PACU? Or can they be sent anywhere else like a medical floor? And then we'll kind of check on them frequently as to see when the dispo may change. Is it going to be a quick dispo, less than 12 hours, 12, 24 hours, or greater than 24 hours? And then again, once they're dischargeable, we need to get the check boxes in on the right-hand side. Are the parent or guardian present so we can get them out of here? Can we move them to a holding area? Sometimes we use the playroom as a holding area if we need to for dischargeable patients so we can get other patients in the room. Are there any special follow-up that would prevent them from getting out of here? Any other barriers, medical transport, home care, ACS foster care, any medical equipment supplies, ventilator dependent? And then tasks may be done after the patient has left. We notify the parents. Any prescriptions need to be done immediately. Discharge instructions, any special discharge needs. Next slide. And this is the pediatric floor PICU rapid intake form. So if we're getting admissions from a disaster quickly and need to go upstairs, instead of getting a whole hour-long H&P from the intern, it's going to be a quick in and out. Obviously, we're going to have senior staff on call, hospitalists to be there to kind of deal with this and not get bogged down with things that aren't important. And this is kind of the cheat sheet that we're using to get people up and dealt with immediately. Next slide. We also have a surge plan in place for the pediatric ICU to determine if it hits the fan where we need to move these patients. There's we have about 11 bedded PICU, which we can kind of stretch out to 12 beds for sure, and then move on from there in case we need it. It's actually kind of happening right now because we have 8 patients in the ED right now who are admitted who are PICU patients that need PICU beds that we don't have. Initially, some PICU beds can be doubled up to provide 3 additional beds in the ICU. It just depends on the equipment that we need to get those patients up there. We have other rooms, epilepsy room, another 2 rooms that we can isolate patients in that can be used as PICU beds on the floor. And then we can move from there. Neonatology also has been very, very integral in this because they can take babies who are less than 28 days or less than 44 weeks gestation to the NICU if there's a PICU surge, which is nice. And then also we can move patients from adult teen patients who are usually greater than 12 if need be to medical ICU beds if it really gets bad. Next slide. The NICU also has a disaster evacuation plan just in case any disaster happens in-house, be it any gas issues, any kind of flooding issues. We can move those patients out of there. You can see on the left-hand side, it's kind of detailed, and you need to be kind of in the mix to understand the annex and whatever else, but there's room from there. So we have a maximum, usually 28 beds in the main NICU, but we can kind of flex to about 50 beds depending on the situation, and maybe add another 12 beds depending on the status of the kids if they're on isolation or not. Next slide. So for domain 1, this is the basic from the PRQC of what we're looking at and how we're doing things. If you move to the next slide, this is where we're at for the check boxes, for things we know. Yes, we know who our emergency manager is. We've collected all contact information. We have a committee. There's pediatric expertise. We have the contact info for all the pediatric people that need to be involved and are involved. We have the disaster plan, and the policy does include specific needs to pediatric patients. And we have been doing drills in the last couple of years. At about, it depends on the drill. If it's a general drill where we have adult and pediatric patients, like a bomb going off somewhere in the city, it's about 25%. We usually include pediatric patients, or we have specific drills which will include 100% pediatric patients. Next slide. We did a tabletop drill in May of 2017, where we had multiple school buses bombed in Queens. About 300 kids were injured. 69 were to arrive at Maimonides Medical Center, and by the end of it, arrived to us. Incident command was activated. We were barring events from the adult units and nursing homes, not taking them off patients who were on them, but barring the ones that were not used. And we actually did the rapid DC on both the floor and the ICUs and the ED as well. Those were our drill objectives on the right-hand side, testing the surge capacity of the PDD, including rapid discharge, as well as the PICU and rapid patient discharge process, and transportation of patients to the PICU radiology from the ED. We achieved most of the directives and identified improvement in some areas, and the plan was effective, and we'll see that in a second. Could you, next slide? Domain 2, again, this is just the basic PRQC for domain 2 about the points to hit. Next slide. And yeah, we do have in place preparation for local disaster coalition building. We are with the New York City Pediatric Disaster Coalition, as well as the New York City Maine Disaster Coalition. And we've conducted drills with them, and they've been hospital-wide partners were engaged. Next slide. Our tabletop drill included these departments: pediatrics, all departments, ED, PEDS, PICU, NICU, outpatient, surgery, ped surgery, trauma, vascular, ortho, SICU, medicine, I'm going to lump the ED underneath that, and also general and the MICU, radiology, general IR, psychiatry as well to deal with any of the issues post, and then nursing and emergency management, and obviously the ancillary services like security, nutrition, environmental engineering. We estimated that about 75% of our departments were involved in that drill at that point, with the exception of a few like geriatrics, ophthalmology, who we likely should have gotten involved, and a few others that kind of didn't make very much sense to the drill. Next slide. If you look at what percentage of departments were engaged in this drill, about 75 to 80% were involved. And during the drill, how long did it take to recruit those internal departments that we had? It was approximately 20 minutes from the activation of the drill to get everybody into the command center to get the calls made to where we need. We did that via a few different ways. Email, which really wasn't that effective, but for the most part, everybody either carries a pager, which is very antiquated, or now has all those pages sent to their cell phone and blast text message, which we did to notify everyone that there was a disaster drill at that point. On the top portion, the red box, time to determine surge capacity for the emergency department services and surgical services and inpatient services. It was approximately 15 minutes till we figured out where we could put people and how much space we actually had, and then determine essential pediatric equipment and get it was about 20 minutes. Next slide. Overall, after the hot wash, we were about 86% was our overall score. We were hoping for a score of 90, but we failed in a small amount of areas. For the incident command center, initially the disaster plan was not used as a reference. That was one of the things that was noted, which was kind of odd, which we obviously changed. There were good communication between the staff and the ICC. Families arrived, and we didn't have a support center for the family set up as per the plan, which we need to. We also didn't deal with the media immediately. We had to deal with that afterwards. At one point, the incident commander left the room. There was no handoff, which should have happened. We needed to develop a hospital policy about keeping parents with their children, so we noticed that. The structure command of the IC was not easily recognized. We needed some more logistics and planning operations in that. Information sharing with the staff outside of the ICC was very minimal. We needed to have more of that. Psychiatrists should have responded immediately to deal with the issues that were going to come during this disaster. Staffing security officers should also have been activated. We needed pre-scripted messages for all the people involved, which we didn't have, which now we have. Email, again, not the best form of communication during incident. And our plan was to check list and the critical telephone numbers. We rose to the occasion, though, during this issue, but the focus on the staff for everybody else around us who was in the disaster was really not evident. We had to fix that. Next slide. For the PICU and the pediatrics, they didn't hear the overhead page, which wasn't great, but they got the disaster pages. The team leaders worked well during the disaster. RNs communicated, which was nice. The units could have used a whiteboard to figure out patient status, which we changed as well. One patient was transferred from PEDS without any report from the ICU, which wasn't great. PICU staff could have gone down to the ED to help assist take patients up. That would have been helpful to us. But we did have a joint plan for adult pediatric and neonatal patients. And we needed those sign-out sheets, which we actually made. For pediatrics, the leadership and medical staff were duplicating efforts and not communicating, so that was one of our faults. We needed an immediate dedicated support staff like IS to come up and kind of give us a hand with making phone calls and to parents and to PMDs. Discharge rounds were done earlier, which was nice, so it kind of helped us facilitate who was getting out of there. And again, we had to figure out where these discharge kids could go. And we also did some just-in-time training for hazmat and decontamination in the PICU when we heard about this disaster. Next slide. The ED, there was a bunch of stuff over here. I'll give you the overall. We needed more crowd control to prevent bottlenecks, obviously. We needed runners from the ED to get stuff like blood for us and to get patients in and out. The patient tracking system got a little hairy at one point. We needed to cohort the critical care patients. Surgery eventually got involved, but they should have been involved earlier, been down there waiting for them. No one was using PPE. They should have. We noted the need for multiple disaster carts instead of the one or two that we actually have. The ED incident command was kind of overwhelmed with these 69 patients that came through the door, so it was difficult. We noted that two-way radios from us to the incident command would have been better, which we're going to institute as well. Triage went very, very well to figure out where patients needed to go. We needed more controllers, observers, and evaluators to kind of see what was going on because it got a little crazy down there. We put up a doctor and nurse team at triage, which was very, very helpful for us to kind of see where patients were going to go. EMS needed to be kept out during ED disasters. Because they were bringing other patients in that probably weren't necessary. We needed to triage the patients out front to decide what was going to happen with them. At that point, our trauma team was very, very young, so we've kind of licked that issue as well with the whole trauma issue. And the overhead page is difficult to hear in general. And we needed to have more communication for telephone numbers to the person who was running this with the ED. The radiology residents were there, but they were underutilized. And again, they didn't hear the overhead page. Next slide. For domain 3, if you look at the parts of that, we are part of Regional Disaster Coalition, and that's going to be our Tier 1 and Tier 2 hospitals that we showed earlier, FDNY EMS, Emergency Management, the Greater New York Hospital Association, and the HHC hospitals as well. Next slide. Last year, we did an internal surge drill where we basically sat in the tabletop and just discussed how we would get patients out of the ED and which patients needed to leave at that snapshot in time, as well as the floor. It was citywide. There was a hurricane prep drill, so basically the scenario was hurricane was coming, and we had to prepare for that. We identified 15 of 20 rapid discharge pediatric ED patients and one rapid admit patient to be removed immediately from the ED to go to different places or to be discharged. 4 of the 8 PICU patients that we had upstairs were downgrades, and we identified 8 of 20 rapid discharge PEDS floor patients that we can move out of there to increase our surge. NICU was notified, an evacuation plan for them was activated as well, just in case the hurricane would have came to us, but we're kind of higher ground, so we don't think it would have affected us that much. Next slide. Domain 4, we're working on the pediatric equipment supplies drill that needed in Domain 4, and we need to repeat a major drill at this point from where we're at. Next slide. And that's it.
Thank you so much. Lots of great information in there, Dr. Arroyo. I wish we had more than 10 minutes to give you. It sounds like you have learned a lot of lessons and have a lot to share as far as disaster preparedness. But so in the interest of time, I'm going to direct you all to use the chat box to ask any questions of them about their disaster, anything, so that we can keep moving. And so we will move on to Oceana with East Tennessee Children's Hospital.
Can you hear me?
Yep.
Okay, great. So my name is Oshana Bratton. I'm the Outreach Coordinator for East Tennessee Children's Hospital. So my role here at the hospital is doing education, outreach, and patient follow-up with all of our partnering hospitals and EMS agencies. You can go to the next slide. So my teammate Stephanie here at the hospital has kind of helped me coordinate from our side because we're a participating facility as well, even though we're a training site. So the way our team is set up here in Tennessee, we're considered a comprehensive pediatric regional center, which means we have dedicated to this region of the state to make sure that hospitals have the education and support they need to get through their pediatric state reviews, make sure they have the education that they need to take care of kids, and basically just a nonpartisan pediatric expert that they can fall back on. And so in the state of Tennessee, there's 4 levels of pediatric readiness. CRPC, or Comprehensive Center, is kind of at the top. Underneath that, we have a general, which is generally a hospital that has a pediatric designated department. We have a primary, and then most of our hospitals will fall under the idea of basic, meaning they've committed to treatment and stabilization of patients and then rapidly transport those children out. Each of those levels have a different responsibility when it comes to education, supplies, and the level of pediatric care they can perform. Okay, next. So our team, we unfortunately started out with 3 affiliates, and over the course of the last few months, we have dwindled down to 1, but that's okay. So our 1 affiliate is Newport. I don't know if is there a next slide? There we go. Okay. So we are where that little blue star is, and then Newport Hospital is a couple counties over in Cobb County. They are a basic facility. In comparison, our hospital here, we are a 152-bed freestanding independent pediatric facility, so we're not connected with any other adult facility. We see about 60,000 patients, and we have a 35-bed ER. We have a level 3 NICU. Our affiliate hospital is a little bit smaller, and they serve a population of about 35,000 within their county. I'm not quite sure what their annual visits are, but they have a ground transport time of about an hour to us, and historically speaking, they see a lot of sick kids and transport quite a few to us. Go ahead. So about our team, just to give you an idea, of course, here at the Children's Hospital, most of the patients that we see are going to be pediatrics. Our affiliate hospitals see anywhere between 10 to 20% pediatrics, depending on where they're located. The further out they are, they tend to see a higher percentage. And just to give a general perspective, the state of Tennessee, we had about an 89% readiness score across the state when we did our readiness scores back in 2014. Next. So when we went and did our gaps, most everyone is struggling with the weights and kilos when we did our initial assessment. So that, before our affiliates dropped out, is kind of what we were going to focus on. It's still what our affiliate hospital is working on, and then we are working here at the Children's Hospital on revamping our vital signs and doing the escalation bundle. Next.
Let me go back in.
Let's see. Go, yeah.
Go back one.
Yes, please.
Okay.
Okay. So just to give a brief overview of where we are, so our affiliate is working on the weights and kilos, and we had a few barriers with their DUA, which we had finally gotten completed, and then it got lost somewhere along the mix. So we just recently, a couple months ago, got access for that hospital. And so they're working on inputting their data. But they have run into a couple things, particularly with getting their scales locked in kilos, and none of us can seem to figure out how to do it. So I think on these next slides, we have the name of the scale. If anyone out there has any words of wisdom on how to manage this scale, we would love to hear that. But they're in the process of inputting their first set of data and then should be ready to move forward as soon as we can figure out this hurdle. And then here at East Tennessee Children's, we did a complete overhaul of our escalation of vital signs. So we went back to the drawing board, looked at our policies and procedures regarding vital signs, recognized there was a couple things outdated, including what are critical reporting, outliers, what are things that actually need to be escalated to the physician, how are we escalating it, on and so forth. So we completely revamped our policy, and then at our quarterly skills fair, we required every staff member in the ER, including our techs, to come in and do a complete vital sign overhaul. This included reviewing the escalation policy, reviewing where in the documentation that they could document that the vital signs were escalated. A lot of them didn't know that was available, so we're hoping this second round of data will show improvement there. We also required every staff member to come in and practice a manual blood pressure, seeing as part of our escalation policy is that for a blood pressure, an abnormal blood pressure, there needs to be verification with a manual. And so we wanted to make sure that everyone was comfortable doing a manual. We reviewed sizing, correct sizing of blood pressure cuffs for different children and what the recommendations were. We also did a lot of work with our techs, because one of the barriers that we found was that our techs were doing vital signs, were having abnormal vital signs, and as they were escalating, felt that they weren't getting the appropriate response out of the person that they were escalating to. So we did a lot of education with them that they could escalate as high as the physician if they felt like they needed to go directly there. And a lot of it was just empowerment for people to speak up regarding abnormal vital signs, as opposed to just accepting a response that they got. Next slide. I think this is just where our team's progress is, so we can skip that one. So our philosophy is just small steps. This has been very slow going for our group. And so as we make these small steps, we celebrate them and hoping that we can each get across the finish line with at least one completed PDSA cycle. Next. So some of our barriers, time and scheduling has been one of the most difficult ones. Here at the Children's Hospital, we have education agreements with 30 facilities across 7 different medical systems. So we're continually doing education and outreach, and sometimes different priorities will kind of take the lead on that. Unfortunately, we've had a lot of scheduling conflicts with the learning sessions, and as valuable as they are, once you fall behind, it's very hard to catch back up. Other things that have been a little bit difficult are some of our resources. So we have to do manual chart reviews for all of our chart audits, and that has been time-consuming, to say the least. And we've had some people out on leave, which kind of complicated matters further. There's that brand of scale. So if anybody knows how to lock a Detecto brand scale, please, please, please contact me so that we can have some advice on that. And then just general communication, really trying to nail down times to speak with people on the team, as everyone has extremely busy schedules. A lot of our people aren't in dedicated management roles, and so they don't have any protected office time. So we're usually trying to contact them during working hours on the unit. So some of our enablers, I will say the mentor phone calls with Diane are usually my touchstones. Those usually help invigorate the group once I bring that information back to them, and kind of keeps us on track. So I appreciate all her work to keep us on the straight and narrow. Celebrating, again, some of those small successes and just continuing to persevere, keep moving forward, and know that we will be able to get this project done. That's it.
Thank you, Ashana. That was great. It sounds like you've done a lot of work Any quick questions for Shauna? If not, I'll have you, and Pat has some comments on the question in the chat box as far as your scale. So maybe in the interest of time, we'll turn it over to Sarah for the fight or flight response team. Are you on the line, Sarah? We can't hear you.
This is Julia Magana. I can do it if Sarah's sound is not working. She says, I'm here. I can see she's here.
Here, let me try it out. I'm going to unmute everyone really quick. Let's see if I can. All right, Sarah, can we hear you now? Sarah?
That's all right. I can do it.
Okay. All right. Thank you.
No problem. I'm Julia Magana. I'm a pediatric emergency medicine physician here at UC Davis. Sarah, whose voice is not heard at this moment in time, she says, I'm talking, but it's not working. Sarah is our project manager, who's new to this team and has been super instrumental and actually knows a lot more than I do. And Jackie will be joining us here any second now. And she is our pediatric emergency medicine nurse and has been helping with this process as well. Okay, I think we're ready for our next slide. You can kind of see our catchment area is a little small. Actually, we have a huge catchment area here in California. So we're responsible for a large swath of patients from big cities all the way out into very rural areas of California. UC Davis is, our children's hospital is embedded inside of the larger academic medical center. And our children's hospital is 129 beds. We are a level 1 pediatric trauma center. And so a large portion of our ED visits are trauma related. We have about 18,000 pediatric emergency department visits a year and about 80,000 total. Next slide.
Julia, can you hear me?
Yes.
I am here. I made it. I called in on my phone. But you can keep going if you'd like to.
Well, this is our training team here that we were talking about before, Jackie, myself, and Sarah. We do have 4 affiliate sites, Adventist Health in Clear Lake, Adventist Health in Lodi, Enloe Medical Center, and Fairchild Medical Center. And you can see where they are in relation to our department. Some are close by and easily accessible, and then some are a little bit more remote here. Next slide. 2 of our sites consider themselves urban and 2 of them are rural. And when they say rural, they really do mean rural. They are really out there alone and without a lot of resources nearby. 2 of them are considered a critical access hospital and have about 111 hospital beds and 18 ED beds. With annual ED visits on average of 36,000 and PEDS ED visits about 7,000. Okay, next one. Here you can kind of get a breakdown of our team that we're working with. We are fortunate to have a good group. Sarah, how many did we start off with? We also went down in the process. 7?
Yeah, we did. We started out with 7, yeah.
And we're down to this 4 crew here, in which we have several different people at each site that are working together wonderfully and are really helping to make all of this possible for us. Next one. Sarah, if you want to take over, feel free to.
Sure, yeah. I can go ahead with that. So we have 2 sites who are using a random sampling strategy whereby a medical records person actually gathers a random sample of 30 charts for them according to the parameters that they set. And then we have 2 sites who are viewing all pediatric charts, mainly because they're very small sites. So when they get to 30, they put them all in. So our data submission is occurring in increments with the chart review scheduled between the implementation of different interventions to allow us to see changes between data submissions. Next slide.
I don't think they know.
So our team is focused on the vital sign, abnormal vital signs bundle.
I would just say, can I just say, like, great job with the stroke?
Oh, there you go. Okay. So we have a lot of great stuff that our sites have been working on with this bundle. All of them have either had a policy for abnormal vital signs in place or collecting a full set of vitals, or have updated their policies to include this. And for the sites that already did have these policies in place, I think it was really helpful for them to actually look and find the policy and see what it says, and be able to include that in their education to their staff. A lot of educational things have been going on with regard to the abnormal vital signs. We had some sites doing monthly newsletters, which are posted in bathrooms and nurses' stations. We have one really great example. In case, I don't know if they'd be willing to share, but of a PEDS post that includes a lot of great information, and it's really cute, and includes a lot of great information about the abnormal vital signs interventions that they're working on. We have all of our sites have been doing education at staff meetings and during nursing huddles, and have used email to notify and remind staff about the policies, and about changes and goals that we're working towards. We also, all of our sites either have new badge buddies that have the, according to the policy, the abnormal vital signs for pediatric patients, or some of these I think are still coming in the next couple of months, but that's one thing that all of our sites have chosen to do. And then another thing that everyone's been working on is either developing a notification system for abnormal vital signs, or better utilizing the notification systems that are in place. Next slide. So we've definitely run into some challenges with these interventions. A lot of times there's just one person working on this who may not have protected office time like the last speaker said. So the chart review is being done kind of just in people's free time, which, as you all know, can be really difficult to schedule. We have had some issues with getting IT, with a lack of connection between IT and the clinical folks working on our side to try to determine what the thresholds in the EMR are, and how the notification system is actually set up. So that's been more difficult than expected to actually be able to access that information and identify the appropriate channels for changing it. We have noticed similarly that there is a lack of documentation around abnormal vital signs. If an abnormal vital sign, for example, was detected but then went away in the system, a lot of times it may not be documented in there. That alert would go away once a different vital sign was put in. And then finally, we have seen that there is some difficulty with the ownership over the vital signs. So for example, if a kid is fussy in triage and they're unable to get a blood pressure, determining who is responsible for getting that vital sign documented later and what that process is has been another challenge that we're continuing to work on. Next slide. That's the end. Great, thank you guys. That was awesome. Lots of work, I like the idea of the PEDS post. That's really fun. That is a great idea. And so with that, I know Dr. Sand had to jump off. He's with Cardinal Glennon Children's Hospital in St. Louis, Missouri. I don't know if Terry or Mary, either one of you are on, if you'd want to run through the slides. If not, I can give it a shot and kind of read them everyone real quick. Here in so okay, so some of their lessons learned. So persistence pays off. One, stay in contact with your hospitals. I know that they've been really good, and especially in their check-ins with Diana, they've been really great about staying in constant contact with all their hospitals. They ask questions of the collaborative and the group leader. So with Diana, she is the best. I will agree with that. And participating in national meetings. It's a marathon and a sprint. So we sprint to the end of each goal so they can finish as soon as possible. DOAs is a good example of that. PDSA cycles, change strategies, but to keep in mind the big picture, long-term goals and agendas of each group. Be supportive, offer guidance, encouragement to each group, and each hospital is like one of your children. I like this. Each one needs different support and guidance. And to celebrate the victories, and we think this is really important as part of the admin team too, that each hospital has its own victories, and it takes a lot of work by a lot of people who are, we fully realize, doing this sort of in their extra time, that don't have protected time, and it's really, to celebrate these victories, because each one is a win for pediatric patients across the country. Very, very true. And so with that, I'm going to turn it over to Nick Fort with Heartland to talk about your work that you have going on. So Nick, if you're on, go ahead and take it away. Nick? Nick, are you on the line?
It looks like she's muted for some reason.
Let's see. Okay, should be unmuted now, Nick.
Can you hear me?
Yes.
Okay, good.
All right, there you go.
I put an incredible amount of detail in these slides so I can be quick about this. I did that also so anybody could use these if they wanted. I'm going to share a best practice that we've found regarding patient tracking. And just like anything else in emergency management, this is scalable and customizable to meet your needs depending on the size of your hospital. Next slide. When we started this initiative, we recognized that we had this issue when we did a small tabletop. And so then after that, we got together and recognized that there were a few key aspects of this that we needed to be able to make this a successful venture. One being an information and notification center in the event of a disaster or any type of patient surge. We have a location approximately a quarter mile off campus, and we have golf carts and hospital vehicles that we can move people back and forth from. And then, of course, in the event that the disaster or what have you takes that facility, we've also prepared a place on campus that we can do the same. We have MOUs for that center, which we're calling the Information and Notification Center, with local health department, and there is a state-funded mental health resource center in the area called Centerstone for mental health professionals to be present at that center, because the reality of it is not everybody might get reunified. So that's why we took it out of that title. It's no longer the Reunification and Information Center. So we need to be prepared for that. We can provide that service to the community if they need it. We do have various communication capabilities between the hospital and the notification center if we have to use the off-site place that we have planned. It is staffed, if it's off-site, again, using admitting, registration, and case management personnel. We took them completely out of the labor pool so that in all policies, so that we can ensure that this is staffed and is operable, because current disaster research shows that you can plan on 10 people for every suspected patient. So even people that we may not even be treating in our facility, there's a possibility we can get about 10 people questioning that person. Anywhere between 100, 200, 300 people could be surging the hospital. We need to find a place to put these people. Next slide, please. This is an example of one of our center logs. so that we can keep track of who do we have, what information are they wanting, who are they with, and if it is somebody that we need to get into the hospital in the event it is a pediatric example. One thing that is cut off on this form that I've copied on this slide is in the top right-hand corner is a place that we can put the triage tag number for that individual. That will be important in a couple slides. Next slide, please. One other issue is identification. If it is a pediatric patient, we can't always rely that they can give us any information or accurate information. So what we have planned is to have a digital camera in the emergency room with a designated SD card for it, for that incident. And everybody, as they come in or right after being triaged, is going to have a photo taken. And that photo will have their triage tag in it as well, so that we can get the number off of it for cross-referencing. That photo will then be placed on the wall of the notification center, wherever that may be at the time, so that we can pair correct people and that we're not giving one family information on another and potentially devastating them. And again, transport to the hospital, if we use the off-site location, is always available. We've worked very closely with our volunteer corps. They have several golf carts that we can use to take people back and forth, and then our police department has also expressed their willingness to help. Next slide, please. The base issue that we needed to fix was how are we going to track all of these people? Because in a day where everything is digital, it is not likely that any of these nurses or doctors or any other clinical labor pool personnel is going to be able to, one, remember everything that they've done, two, be able to sit down and chart like what they're used to. So we needed to find some process that we could take in order to streamline this information to those people that are either sitting in our classrooms or in our off-site notification center, because that's going to be paramount, especially for a pediatric surge. At the ER ambulance entrance, we have an ER doctor, we have a triage nurse, and we have a patient tracker. We also do that for the waiting room entrance to the emergency room. The patient tracker notes all information available without interfering in the assessment process, because honestly, that all they need to do is listen and record. Photo, of course, we'll take it at that time if it's a pediatric individual. And then we have what's called floaters. Those are tracking floaters that will collect those forms from the triage area from the patient tracker. And all they will do from that point on is walk around with their forms and follow those people and write down updates on where that patient is, what was the last thing done to that patient, where is that patient going to be transferred, are they going to be going to surgery, etc. That is their only job. We have completely taken all of them out of the labor pool as well to ensure that every single patient gets the attention they need to be tracked throughout the disaster. And then each department that may receive one of our patients is going to temporarily move to paper charting, because that is going to help the floaters determine what has happened or what is going to happen. All of the nurses or any other clinical staff can scribble down real quick what happened. Everybody has been trained to put a timestamp on it so that they can keep adequate track and keep everything in order. Next slide. Is an example of one of our patient tracking forms, and we did it in such a way so that just-in-time training could be done. In the event of an actual disastrous event, it's not always likely that you have your specifically trained personnel. We need it to be as simple a process as possible for just-in-time training, because more often than not, that's what you rely on. So each folder that I have put together for the first page are detailed instructions. And the next, to the right of that, you see is one of the patient tracking forms. And again, cut off at the top right is room for the triage number. I put on here name or identifier because, of course, if they're unconscious, we need something to identify them with. As many as they need to write down, that's all we need. And then you can see where we also have emergency contact information and timestamp and a note line for each update so that it can stay in order. Next slide, please. These are our triage tags. The 4 digits at the top right-hand corner, for example, this one is 0602, are the same last 4 digits after each barcode that you see on there. That's important for several reasons. One, if you look to the left, it says EMT wristband. All of this is serrated. We can rip that off and put the wristband on them, the triage tag around their neck. There's various levels of redundancy with these tags. So a surge, if the triage tag gets ripped, if they lose it, we still have the wristband that we can use. All of these barcodes are going to eventually be a level of redundancy for us because this entire process that I'm explaining to you will one day be redundant. Because in 2020, our Regional Disaster Coalition is going to implement what's called EM Tracker. So in 2020, I'd say probably the end of summer, our floaters will be able to walk around with a tablet or a cell phone and scan these bars and do updates. So we've implemented this so that when we do have that, we have a backup plan so that we're not relying solely on technology, because I'm not a fan of doing that. I like redundancy. Next slide, please. This was not something we did quickly. We did do it in a matter of about 3 months, but it took some planning. Like I said in the beginning, first we did an exercise. We identified this was an issue, and we needed to identify those critical aspects. The information center, we need people designated to this job so that we don't even have to think about it anymore, and we know that there are people that are taking care of it with nothing else. It was important for me to make sure that all of our stakeholders, which is our staff, are included. I referenced our patient access director who helped me revise all of these forms and the process itself, because it was important to me also to make sure it's as easily executed as possible and that it is user-friendly and that they're comfortable doing the job, because you don't really accept a job and expecting to be a key player in a disaster. And I understood that. So we wanted to be an easy and comfortable process. We did 3 drills to exercise this so that we can make small changes. And then when we were confident that we had come up with a process that would meet our needs and that was going to be efficient in the event of a disaster, we executed it in a city-wide exercise. The city of Marion, which is where we are located, did a full-scale active shooter at the junior high. So I saw it as a wonderful opportunity to use it also for pediatric experience. We used 20 nursing students from the local community college as victims, and by the end of it, every single patient was tracked. We knew where they were going at what time, and we knew where they went. We also tracked their transfer. We did not actually transfer those students out to different facilities. We did that functionally, but with all of the communication aspects that we had in place, all of the patients were successfully tracked. Next slide. And that's just my contact information.
That's great. Lots of great information. Thank you so much. Once again, use the chat box. I'm sure there's a lot of questions around this great tracking system you all have it put in place. But with that, we'll move on to Ashley out with Lone Star Kids.
Hi, I'm here. Can you hear me?
Okay. Yes, we can hear you.
Okay. Hi, We are with Team 5, Lone Star Kids. My name is Ashley Yawn. I am the HCA Division Pediatric Network Coordinator, as well as the team trainer. Next slide. We are a network of hospitals, with Medical City Children's Hospital being the training facility for our team. We are a children's hospital inside of an adult hospital. Our team consists of myself. Like I said, I'm the Pediatric Network Coordinator for all of our North Texas Division. I'm the team trainer. I am the Pediatric Champion for a few of our facilities as of this moment, and I'm also the data steward for all the facilities as the second backup. Part of my role is I collaborate with all the units within the Children's Hospital, including the ED, to ensure that every patient is getting the best care possible. So not only are we rolling out the bundles in our emergency department, but we're making sure that once they get to the inpatient units as well, that they're following our weight and kilos, that know to recognize abnormal vital signs, and they'll be part of our intra-facility and disaster planning process as well. I'll work with the pediatric educator at the Children's Hospital, along with our new pediatric quality coordinator, to make sure that we're measuring any kind of metrics that are related to pediatric outcomes, and we put in any kind of performance improvement measures that need to happen. We are actively working on the SPS project as well. And I also work with our area, our division ED educators as well, to make sure that we team up together and go out and do monthly to bi-monthly education opportunities for pediatric care in the emergency departments across division. Next slide. Some facts about our Lone Star Kids team. The HCA network in North Texas is 22 affiliates. We have 13 general hospitals, 9 freestanding EDs. Medical City Children's is the only facility with an inpatient pediatric unit and pediatric intensive care unit. Our PICU consists of 20 beds, with 2 of those being reserved for ECMO, and our inpatient pediatric unit consists of 65 beds. We are a level 2 pediatric trauma center, and our ED alone sees over 50,000 patients a year. And just in last month, we increased our EMS traffic for pediatric patients by 48% from 2018. We also added a new hospital right across the street. It's a new heart and spine hospital. They don't have specific pediatric units. However, we've already had 3 come to their ED over there. So we are expanding all of the education for the PRQC project to that facility as well. And we have 2 new freestanding EDs that are co-branded with our Children's Hospital. We also have a team that is not within our HCA North Texas Division, Cogdell Memorial Hospital. They're a rural hospital out in Snyder, Texas, kind of close to Abilene, and they see around 1,800 pediatric patients a year. Next slide. So some of the barriers and enablers that we've seen that's kind of made this, that we've seen that might enable us having some success is we, number one, have had a large amount of nurse and leadership turnover in our EDs across North Texas. It is, however, stabilizing as I speak. So right now, where we don't have a pediatric champion or maybe even a director that has taken the role, I mean, they've accepted the role, but they haven't exactly resumed the role yet. We have some backtracking on data at some of those facilities. We also have had some of the smaller facilities struggle with getting certain pediatric supplies just due to their PAR levels and the budget not necessarily allowing for them to have some special order supplies. So we've just kind of done an exchange program with the pediatric hospital where if they need a certain size pediatric trach, we kind of loan them 1 or 2, and then if they don't use it and it's getting close to expiring, we just trade them out before they expire. We Also have noticed, like across division, that some of the pediatric education and clinical competencies for pediatric care weren't necessarily the same. Some of the smaller hospitals were still using some outdated competencies and education. So along help with our ED education team for division, we have updated those clinical competencies for pediatrics. We've updated the pediatric education, and part of that is a pediatric division skills day and lecture that we do for all of our new hires that come through division, and it's one day where all the nurses that are new hires for every ED in division comes and gets the same education, which includes all the information on the PRQC bundles. And then we have also worked with them to educate them on maybe like child development type stuff and some child life resources to make the pediatric day a little less anxious and scary for some of the facilities that aren't as pediatric focused. Successful strategies, we did develop a child life resource book for all facilities. We keep it updated. If there's a new procedure that maybe we don't do as often that hasn't been added to the book, we've been adding those. We have developed a core pediatric nurse internship for the Children's Hospital. And we also open those classes up to all employees in our North Texas division. We have standardized all policies for all procedures that have anything to do with the care of pediatrics. And then, like I said previously, our division new hire pediatric lecture and skills day has been rolled out across division, and it's one entire day in every internship that starts. We also have a pediatric trauma core curriculum class that all new hires that work with pediatrics, whether it be inpatient or in an ED setting across division, they are required to take this class within the first year of hire. Next slide. So some of our pearls of wisdom or best practices was we kind of have it in our favor that all of our facilities are co-branded and all of our training and policies for the division are the same when it comes to pediatrics. So that is that works for us, and it makes it easy to standardize what we're sending across division. We have a collaboration with the pediatric medical director on each bundle, and then he also helps to identify any outliers and help us resolve and put in a performance improvement plan immediately. And then we just continue to focus on strengthening pediatric healthcare. We make it a fun learning environment. We don't want anyone, even if we find an outlier, we don't want them to feel like we're criticizing them. We use it as a learning opportunity and just really stress on the importance of pediatric care, how it's different than adult care, and really work on strengthening our nurses across the board. Next slide. Some takeaways. As I've been doing data entry for about 6 of our facilities, I have noticed that a lot of our freestanding EDs, it usually takes, just for a 30-patient pool for any bundle, it takes about a 1 to 3 month patient volume for me to reach that 30-patient goal. Some of ours, though, we have 2 that see at least probably 500 a month, so those don't seem to be a problem. We are currently missing 5 to 6 pediatric champions for our division. The team trainer, which is myself, I've absorbed the load, and I work with the ED directors for any interventions or patterns I'm seeing for each bundle that I see that needs improvement. And doing this data myself, I'm seeing that the project can be successful with a strong trainer and support from the leadership team. We are very fortunate to have support from our division and from the administration at our Children's Hospital. So that allows me to take a day or 2 off of my regular schedule across division and to sit down and do data, and they're very supportive of that. We will start Bundle 3 baseline on December 1st, and we'll be starting our disaster bundle in January 2020 with the due date of our division disaster management policy to be renewed. Any questions?
Great, Ashley. Thank you so much. I know you've taken on quite a bit of work, and just tons of work. So any questions, go ahead and direct them to Ashley in the chat box. We probably have time to squeeze in New England. Oregon, I think maybe we're going to try to push you to December if you're all right with that, or if not, we can go a little long today and try to push through. What is your all's opinion? Would you prefer to maybe push you all to December or try to get it done today?
This is Rachel. I have to jump off at 10:30, so.
Okay.
This is Michael from New England. We can go real quick.
Okay.
I think December will be better because I have other members that were supposed to speak that also need to jump off. So.
Sure. So I'm sorry. We'll push you guys to December so that we have plenty of time to hear you all, and I think we'll have time to get to New England, you guys. So go ahead.
And then maybe Beach will be back.
True. Good point.
Thanks.
Yeah. Thank you. Okay, go ahead, you guys.
Okay. Can everyone hear me? Okay. It's Michael Goldman.
Yeah.
Great. So congratulations to everyone with all their awesome work. Next slide, please. So this is our team. We're a regional team. One of the highlights of our team is that we are co-managed by 2 major children's hospitals in the Northeast region here. And then you can see by the
Excuse me for interrupting. Which group are you representing?
New England EMSC.
Thank you.
Sure. So we have 3 states. We have about 3 or 4 of our hospitals, affiliate hospitals, are within the Yale New Haven Children's Network, and then the other half representing different independent hospitals. And there's Connecticut Children's Hospital right in the middle of the state as well. Next slide. Our enables and barriers are relatively similar as they were in Austin a year and a half ago, or whatever that was now. We have a really strong regional EMSC program, which has allowed us to benefit from the experience of Victoria and the administrative expertise of Christina, which has really helped to keep us all organized with the incredible amount of team personnel turnover and organizing our meetings and such. We found that because we're such a diverse group of hospitals involved with working on pretty much different bundles for each of them, that we really benefited best from individual check-ins as opposed to monthly group-wide or regional-wide meeting participation. And again, with everyone's schedule, that was what we ended up finding most fruitful. As trainers, we really felt that forcing folks or helping folks formulate aim statements really helped us help them. But at the same time, we definitely had experiences where some of the QI jargon was hard to navigate and maybe was a little bit of an impediment for some of our teammates. Next slide, please. I just got a text from Laura Schilling, who's the amazing pediatric champion of all champions from our region here. As Springfield Hospital was the leader of charts documented and charted as of the last newsletter, she's not feeling well and therefore can't necessarily speak to all the amazing work that's been done up there. So if you would just go to the next slide, I'll just hit on a few bullet points from what we've been talking about through the last several months. So yeah, I won't read through all of this by any means, but I think that they're a model participant in this initiative because A, they've identified themselves as a high needs hospital in that they are a critical access facility. They've had multiple changes in both staffing and pediatric resources in the region, and there was a real thirst for ongoing quality assurance and education with respect to pediatrics. So they were sponges. I mean, they took advantage of everything that was on the website, everything that was offered through other regional initiatives, both through New England and Massachusetts EMSC and Vermont as well. So they've really put a lot of PDS cycles through, and you can go ahead to the next slide. They worked on the 2 major bundles to start off with, the weight and kilos and the vital signs, really focusing on making sure, again, that only kilogram weights were documented, and then subsequently that they both documented all vital signs, pain scales, and escalation of abnormal vital signs appropriately, and they've made significant gains throughout. So I'll skip the nitty-gritty because, again, I can't really speak to the fine details, but just a real kudos to their hard work. And then, yeah, skip this slide too. They really highlighted, again, some of the regional care offers they were faced with, that encountering this initiative at that time was really helpful for them to keep pediatric skill sets to par. And they really felt it offered a nice opportunity to educate both from quality improvement initiative, but also just pediatric care in general. And then we can go to the next slide. Ewelina Lidas is on the line, so I'll definitely turn it over to her to highlight her work at Hospital Central Connecticut.
Hi, this is Evelina. Can you hear me?
Yep.
Okay. All right. So I am the ED educator here at the Hospital of Central Connecticut. We have two campuses, one in New Britain, Connecticut, and the other in Southington at the Bradley campus. We see about 87,000 patients per year, and we are an adult hospital with, pediatric services in the emergency department. Myself, along with Dr. McDade and Allie Fangula, one of the nurses, did a lot of work surrounding this initiative. Next slide. Okay, so what we realized is we do a pretty great job with weight in kilos. Essentially, we were going to kind of work on that, but then decided to change it over to vital signs. We realized that our nurses were having challenges with getting all 5 vital signs documented in triage. So we made a goal by December 2019, 90% of our pediatric patients with an ESI level of 1, 2, or 3 will have all 5 vital signs documented in the triage note. Since our Bradley campus sees 20% of our total patient volume, we sampled 20% of the 30 charts from them and the remainder from the New Britain campus. Initially, we were at 43% compliance. Our first PDSA cycle included making sure that we have the appropriate equipment, the correct size blood pressure cuffs in the triage area, and other, equipment that is required. We educated our staff. We do hold daily safety huddle meetings 3 times a day, so we made sure that our staff were aware of this initiative, what the expectations were, what the importance of documenting that actual blood pressure is. And we had a go live date of July 1st. Since that time, we did random 24-hour audits for 24-hour time periods, just to see what the compliance was. And over, since that time, it had been increasing steadily with compliance. And of course, we were following up with the non-compliant folks throughout that time. So in our last post-intervention data actually showed an increase from the 43% compliance to 93% compliance with our interventions. That is it for us. Oh, okay, sorry. So the pros, so all of our providers were very, very, excited to see that the 5 vital signs were all in. They, it made transfer out to actual, local children's hospitals much more effective. Identification of any issues was much faster than previously. We had lots of opportunity to mentor each other and develop regional relationships within our group of folks here. Some deltas, are the blood pressures accurate? Now, some of the other groups spoke to exactly, how challenging it is to make sure that we're getting accurate blood pressures. And so we certainly, found that to be a little bit cumbersome and challenging. The data entry process is very intensive. So we were lucky to have a pediatric champion here that was willing to put in that work as part of a project, and definitely lots and lots of calls with the regional group to make sure everybody was on task. Next slide.
So this is Marianne Kelly. I am one of the trainers from Connecticut Children's, and I just wanted to highlight some of the work that's been done by the other members of our team. So next slide, please. I'll go through this quickly. We just wanted to highlight that of the other sites that we have in our group, we do have actually all 4 bundles represented, which, as Michael said, has made this an interesting challenge for all of us and a great learning opportunity for everybody. And so I won't go through each individual site. Maybe we can just skip to the next slide while I'm talking, but I do want to call out that each of our sites is doing phenomenal work that allows them to make improvements within their own sites. They highlight, as others have mentioned, the acceptance of their staff with these changes, as well as the amazing work done by the data stewards and pediatric champions at each of their sites. From this, we've been able to increase at each of the sites all of the markers and make some great policy changes along the way. Next slide. And so just as we think forward to kind of the final stages of the collaborative, we want to make sure that our colleagues get the recognition at their sites that they deserve. I know we all kind of have mentioned this, that we do not get protected time and our sites do not get protected time to do this. And the work that everybody is doing is phenomenal, and we want to make sure that they get recognized as often as possible. We look forward to the completion of this collaborative and then the ongoing work with the relationships that we've fostered throughout our region. And we're proud of the work and the education that everybody has received throughout this, so we look forward to MOC and CEU credits as well. And I think, next slide, I think that's all we have.
Great, thank you for that update. You guys have done a phenomenal amount of work, and yes, it's hard with all 4 bundles represented and coordinating across all the different groups, so very great. And with that, we are slightly over time. I just wanted to remind everyone that the November newsletter just went out. You should have gotten it. We encourage you to share it with your ED leadership, with your hospital leadership, so that they know how hard you all are working on this. And like everyone has said, we know a lot of you don't have protected time for this, so at least to show them maybe the amount of work that's going in and some level of recognition with all your hard work would be great. December learning session is December 3rd. We're going to have more team presentations. And all of this is up on the website, so feel free to email me if you have any questions. And with that, I want to thank all of our presenters. So much amazing work. Thank you for taking the time to put these slides together and give us all an update on what you all have been doing. We really appreciate it. And I don't know, Diana or Kate or anyone? Yeah, thank you.
Yeah, you all did an amazing job. Thanks for presenting today and taking the time, and thanks to everyone else for listening.
Thank you all.